I'd like to start by thanking the meeting organizers. It's always a great honor and a pleasure to be here. And as a skier, as you can see here, I also love to do the skiing. That's a picture of Davos, not North Carolina. So I guess this is an old version of my talk, which was missing the disclosure slide. Right, so I do have companies, and we are trying to develop commercial versions of the PAM50 assay. And so I do have a conflict of interest for much of what I will discuss. But I thought I would start where the last meeting finished, right, which was with some of the previous guidelines here, in large part based upon some of our immunohistochemical surrogates of the different subtypes. So, as always, between 2 years ago and now, we want to try and improve things and make them better. So, in some studies done by Alish Prad in my lab, what we figured out is that the immunohistochemical surrogates are maybe not a perfect surrogate for the gene expression defined subtypes. In particular, the IHC surrogate calls many luminal B tumors luminal A by the IHC test. So we then set about to try and improve upon this. So what we did was to take a set of tumors where we had the IHC and the gene expression, and we looked at luminal A versus luminal B and tried to find the genes whose high expression defines luminal A. And in this supervised analysis, it's this gene set right here. And probably not surprising to many people in this audience, the progesterone receptor is a gene whose high expression defines luminal A and is lower in luminal B. So what we then did was to take the immunohistochemical defined luminal A subtype and then subset it based upon a quantitative measure of PR greater or less than 20%. And within these luminal A tumors, it did predict survival. And when we did the multivariate test, it included other features, including Ki67. Both Ki67 and PR made the final model. So our new suggested immunohistochemical means of finding luminal A tumors is similar as before, but now we're going to include Ki67 and a quantitative PR. And the goal here really is to find the good outcome luminal A's who appear to do well when given endocrine therapy alone. And so here are the somewhat changed luminal B definitions. However, as was brought up before, number one, these definitions do not fully recapitulate the gene expression defined subtypes. And of course, it's technically challenging. We're now asking pathologists to score 14% Ki67 versus 13%, or 20% PR versus 21%. So that's tough. But I think with a community effort, we can establish controls and standards, and we can make this a reality. Now, here was an interesting figure from that paper where we sort of did some likelihood ratio testing, comparing the IHC4 biomarker, which is a combination of ER, PR, Ki67, and HER2, I believe, versus our subtype definition versus the PAM50 risk of relapse score. So here's the amount of information you get from IHC4, which is very similar to these new updated IHC intrinsic subtypes. And what you can see here is that by gene expression, you get more information. So if we do the likelihood ratio test where we condition on one of the IHC markers and then ask if the other IHC marker adds value, it does not. But then if you do the gene expression on top of that, it adds value. So for me, the take home here is that the IHC is good, but that the gene expression is better. And I'm a firm believer that the gene expression is better and more objective and more reproducible. However, not everyone has access to these gene expression tests, and in their absence, I think the IHC is helpful. So, over the years, there are now many gene expression tests for breast cancer patients, including our PAM50 and risk of relapse, Oncotype, MammaPrint, Genomic Grade Index, Breast Cancer Index, EndoPredict, it's getting quite complicated now. And many of these are very good and validated assays. And so, of course, I will review some of the PAM50 data over the last few years and discuss a few of the others. So, thanks to Mitch Dowsett and the ATAC investigators, I think Mitch and those deserve a great hand of applause for running many different biomarkers on this study. In this case, we were able to, actually I didn't do this, the nanostring version of the PAM50 test was tested. And here's how the risk score performed according to a predicted 10-year risk of distant recurrence. And you can see here's the no positive node patient category. And as has been shown before, your risk score is about proportional to your predicted relapse. Here's 1 to 3 positive node patients and 4 positive nodes. So here I think was the interesting analysis, again a likelihood ratio test. In this case, we're conditioning on the risk score, and then asking, I'll go back to get rid of that, thank you. So we condition on the risk score and then ask whether the Oncotype DX recurrence score adds value, and it did not. If you do the reverse and condition on Oncotype DX, the ROR does add value. Now, also developed on this data set was the IHC4 biomarker, and in this case, if you do the gene test and then the IHC test, the IHC test adds value. If you reverse it, the same is true. But what I will point out is that this is the training set for the IHC4 assay, and thus this is probably as best as it will ever behave. So my take home from this is that the risk score is adding value even if we know some of these other features. So if we do a comparison between the risk score categories of high, intermediate, and low and the Oncotype DX categories of high, intermediate, and low, they're quite similar. And actually, they have a nearly identical number of what were called low-risk patients on this data set. I think the one different thing was that there were fewer intermediate risk patients by the ROR who were basically moved over to the high-risk category. And then if you look at the KM plots over here, you can see that the patients that were called high risk were in fact high risk. So now over the years, over 5,000 patients have been tested with the PAM50 assay in a completely, particularly on the bottom half here, a completely locked down, pre-planned version of the assay. So hopefully it's abiding by the biomarker rules that Dan Hayes has shown us. Now, here was a seminal and literally practice-changing finding from the Oncotype DX assay, where the benefit of CMF chemotherapy was really all in the high-risk group. Thus, many patients in these groups can now possibly forego the systemic adjuvant chemotherapy. So I always have to dig down into the fine details of these studies. And of course, what I wondered is, in the recurrence score high group, what is the subtype composition of this? So this is an ER-positive data set. However, it's still a heterogeneous group. So we did not do expression profiling on this study. So in lieu of that, we took one of our own published data sets of about 500 patients who had received no systemic adjuvant therapy. We grabbed the 395 ER-positive node negatives, which was similar to the inclusion criteria for B20, and then asked what was the subtype distribution. And a little bit to our surprise, what you can see is that about 16% of these 395 patients were what I would call non-luminal subtypes, basal-like subtype and HER2 enriched. And here's the outcomes of those patients. It pretty much looks like what we've seen many times before. So we, as we've done many times before, ran a version of the Oncotype algorithm on our DNA microarrays. It looks pretty much like the Oncotype outcomes as we've seen before. But what I'll note is that that high score group is where most of these non-luminal patients are. So I will predict that some of the benefit in the high-risk group is coming from what I'm going to call these contaminating basals and HER2-enriched patients. And so it really begs the question of what is the chemo benefit in ER positives if we remove these contaminating samples, right? So time will tell, and hopefully as we retrospectively analyze a number of these studies, we can figure this out. So of course, here's one of the trials we're all awaiting the results of. This will give us level 1 data according to the biomarker guidelines, if successful when it reports, and we hope to get the results in another year or two. So here's another seminal study from our Oncotype, the Genomic Health folks. In this case, again, estrogen receptor positive but node positive cohort. And what we can see is that, again, there was a benefit in only the high-risk group. So the challenge here, I think, is now we've got node-positive patients who we're predicting may not have a chemotherapy benefit, and so this is a tough decision. What do we do with these people? I'm thinking PI3 kinase might be some of the answers, but again, that will be figured out in many of these trials that are ongoing now. So here is the very important study that has arisen from that, where this will be formally tested. Again, 1 to 3 positive nodes, hormone receptor positive. Patients with the low scores will get randomized to chemo and hormone therapy versus hormone therapy alone. This trial is going on, and I'm not sure when it will finish, but it will soon. And of course, the other genomically driven study that we're all anxiously awaiting the results of are the MINDAX study, which is prospectively testing the value of the MammaPrint assay in comparison to the clinical risk assay. This too is expected to report in about 2015. So at the next St. Gallen's meeting, we may have some very interesting and large genomic trials to be evaluating. So I thought I'd end with some of a discussion on the basal-like subtype to discuss some of the recent findings from the Cancer Genome Atlas. I think Will Folks did a great job of summarizing that, and some of what I would say will complement that. So of course, and I'm sure the audience is aware of this, right? About 75% of triple-negative breast cancers are of the basal-like phenotype. So when we're studying triple negatives as a clinical trial, we're basically studying basals. And if we're going to make therapeutic advances against triple-negative breast cancer, it will be because these agents are effective against the basal-like subtype. Also keep in mind that 25% of basal cancers are not triple-negative. They're typically ER or PR positive, and so they're over in many of these endocrine therapy studies, and they don't do very well. Now, over the years, we and others have figured out many of the genetic determinants of the basal-like subtype, which include P53 mutation, BRCA mutation, RB deficiency, and MYC amplification. So the good news is we know the genetic causes of the basal-like subtype. The bad news is most of these are not therapeutically targetable. So we still are searching for many targets. I think there are quite a number of promising targets. Some of these have been mentioned already. Some of these will be mentioned in the days to come. The baseline prognosis is poor, so we have to do something. Chemotherapy benefit is high. Is there a specific chemotherapeutic benefit? We don't know. This is possibly where the carboplatin or cisplatin question comes in. I think the jury's still out on that. Is there a PARP inhibitor benefit in the non-BRCA mutant basals? So far, the data looks like there's not. I think we're going to hear some exciting data about possible immune cell modulators. About half of basal-like cancers have intense immune cell infiltrates into them, and that was a good prognostic feature, as Will Folks showed. The RAS-MEK pathway, I think, is important for this subtype, and as we heard earlier, PI3 kinase and mTOR inhibitors may also have a role in here. A little bit was shown earlier, but I can show it again from our Cancer Genome Atlas efforts of sequencing 500 tumors. In this case, we had 93 basal-like cancers. The somatically mutated gene list in basal-like breast cancers is very short, as Will showed. Basically, P53 PI3 kinase, RB, and then very low-level frequencies. So, and in this case, it was 80% of the basals had P53 mutations. So in my mind, a P53 mutation is a required event and likely an early event for basal cancers. But then beyond that, it's not many other repetitive somatically mutated genes. This finding was highly reminiscent of the finding from the Cancer Genome Atlas when we were studying serous ovarian cancer, where in ovarian cancers, 95% of these cancers had P53 mutations, right? This huge frequency, and then again, almost nothing else was above a 10% frequency, right? So for serous ovarian and basal, it's P53, and then a very small list of genes. And so then we wonder, well, what is the main cancer driver in this type? Let me just say this before I get to that, because I think this was important. So in our TCGA data, if you look at BRCA1 germline variation and somatic, and BRCA2 germline and somatic, then about 20% of basals had a deleterious variant, right? This could be relevant for potential sensitivity to PARP inhibitors. And the key here is you really have to do the germline and the tumor and BRCA1 and 2 to cover all of that, right? So that's a lot of expensive testing, but if we can give a drug that has the activity like olaparib or some of the other PARP inhibitors do in known BRCA mutants, then I'm going to say it's worth it and we need to figure out how to do it. So, as I suggested, given P53 mutations and not much else, what are we left with? Well, the answer is the copy number world is all over the place. These tumors, as you probably know, are highly aneuploid and have many copy number changes. So here are the basals right here, and you can just sort of eyeball it and compare it to the ovarian cancers and note that they have very similar overall copy number profiles. 1q amplification, 4q, 5q loss. These two are very specific for basal cancers and also common in ovarian. MYC amplification, and actually you can see here, the percent of the genome changed is huge in basals and ovarian. So it's the copy number landscape where I think most of the action is going to be for basals and thus triple negative cancers. So now I'll end with a few of our therapeutic findings, because I do think there is subtype specificities to chemotherapeutic agents, right? And I think it'll also be worthwhile to try and figure some of this out. And this is one of the first clues that we did, where we ran our PAM50 assay on this Canadian MA5 study, which was CEF versus CMF. And what we can see, as was known and previously published, was that the benefit of the CEF was in the clinically HER2-positive tumors. Possibly the new information here was that our HER2-enriched subtype also showed an anthracycline benefit, and none of the other subtypes did, right? So a basal-like cancer, right, had a similar outcome when given CMF versus CEF. And if we can spare anthracyclines to a patient population but have the same outcomes, I think that's probably a good thing to do. Now, of course, you're probably wondering, well, the HER2-enriched subtype, most of those tumors are HER2 positive, so you're just renaming HER2 positivity. Well, no, that's not the case, because if you do a multivariate test where you condition on HER2 status and ask whether the gene expression subtype is significant, the answer is it is. Or you can do the reverse. If you condition on the gene expression subtype and ask whether clinical HER2 status is important, it is, right? So it's the tumors that are HER2 positive and of the HER2-enriched subtype where the anthracycline benefit may lie. So I'll close with a little bit of somewhat provocative data on taxane benefit, right? So in this study up here, Miguel Martin ran a single-agent neoadjuvant study of doxorubicin or docetaxel given in a 3-week schedule for the docetaxel. And the one thing we saw was that the basal-like subtype benefited from or had a statistically significant higher PCR rate for the 3-weekly docetaxel. And of course, study from Dan Hayes and my colleagues at the CALGB on 9344, which was a study of AC with and without the taxane. In HER2 negative, ER positive, there was no apparent benefit of the taxane. And in HER2 negative, ER negative, a crude surrogate for basals and triple negatives, there was a taxane benefit to the 3-weekly schedule. Here's a paper we had come out maybe just a month ago, again, in collaboration with Miguel Martin, where we looked at the benefit of weekly paclitaxel. And in this case, it was FEC times 6 versus FEC times 4 plus a course of weekly paclitaxel. Here was the subset of 820 patients who were in the correlative science study. There was an overall benefit for the weekly paclitaxel. We did intrinsic subtyping. Subtypes looked prognostic as they always did. There was no interaction between subtype and weekly taxane benefit, surprising to me. However, what we did see was that our proliferation index was predictive of the weekly taxane benefit, and it was the slowest growing tumors that got the benefit from the weekly taxane, right? And the high proliferating tumors, which would encompass the basals and the luminal Bs and the HER2 enriched, did not gain a benefit. So it could be that dose and schedule matter, right? The low dose benefits the slow growing tumors, and the higher doses benefit the faster growing tumors. Clearly, more studies are needed to figure this out. So in closing, I, of course, am biased, right? And would think tumor subtyping is important and we should do it. And I would, of course, choose to do it first by gene expression and second by IHC. But of course, I always advocate use only validated assays and validated combinations of biomarkers. I will argue gene expression tests are reproducible biomarkers that are providing information not provided by the standard clinical variables, and that, as I was just alluding to, dose and schedule probably matter. And so as we now untangle the heterogeneity of breast cancer subtypes, we probably have to simultaneously untangle dose and scheduling of these different chemotherapeutics. And I think then, as Matt Ellis so eloquently showed us, molecular classification for prediction is the future. DNA mutations and copy number are going to play a leading role there. And I think in the next few years, we're going to have combinations of gene expression tests, sequencing tests, protein tests, and it will get better, but it will be complicated. So in closing, I'll just thank the many people involved in this project. As Dan Hayes alluded to, this is a community of clinicians, pathologists, basic researchers, biostatisticians, clinical trial groups, and it really requires everyone. So thank you for your time and attention.